we need to do a careful nasal examination in the office. Sometimes we need to use what we call a nasal endoscope, which is a light source that we look inside the nose to study the anatomy better, to make sure there's no allergies or sinusitis or other pathologies such as a mass in the nose or something else that can cause this. And then once you've eliminated everything else, then you study the anatomy, the internal and external anatomy of the nose to figure out exactly what's causing the obstruction. If a patient has had significant trauma when they was younger, some people you see their nose is totally deviated to one side, or it's a C-shaped deformity, like somebody knocked them from one side, knocked the nose over, and it's been sitting in that position for years, then it's a different story. We really have to re-break the nasal bones and bring the nose back to the midline in order to correct the deformity and to give patient a better chance to breathe through his or her nose. And that is more extensive surgery, and of course that will change the external appearance of the nose. If we just try to shrink the turbinates down, that can be done in the office under local anesthesia, local anesthetic. And if you want to do a septum, septoplasty, or straighten out the septum, that's usually done in the OR. And it's a day surgery, meaning you come in and you leave the same day. You just have to have someone with you to drive you home, because most of the time it's done under general anesthesia. If the goal is to help the patient breathe better, and that was documented on physical exam in the office, I could say 100% of the time, almost close to 100%, they will feel better. So I would say very successful.